Okay, so hi everyone, good afternoon, welcome back. So this is part 2 of your 25 most important clinical pathology MCQs, and I hope you all remember me. I'm Dr. SHruthi, and for those of you who have just joined in new, so let me introduce myself. I'm Dr. SHruthi, and I'll be the faculty. I'm the faculty of pathology for Medicoz Community, right? So I hope all of you know about us. So we are an online education platform, and what you're seeing on your screen is the next. This is the schedule for the next few classes. So your February will be jam-packed with us, and you have amazing sessions coming up. So please note down this time and date, and please log in accordingly, right? And also keep updating yourself with our YouTube channel, Medicoz Community YouTube channel, and you'll get all the updates there. And for all the courses that we offer, you can go on to medicozcommunity.com, the website, and you can get more information. So let's move on to our topic. So as I said, this is part 2 of our pathology session. So we did the part 1 last month, and we'll be starting and continuing from question number 13, right? And one more thing, so let this be a little interactive. Please type in your answers in the live chat box and I'll reply any doubts. Please do ask, okay? Nothing to shy. And also kindly excuse me for my voice today. I'm down with laryngitis, so you will have to bear with this voice for the next 40 minutes to 1 hour, right? Okay. So let's move on to the first question. Okay, so are we good to go? Right. So let's move on. So what is this question? So this is question number 13 because it's part 2. Okay. So here let's read the question. A child is detected to have an empty scrotal sac and they have done biopsy, and what they're showing here is the biopsy picture. So what is the question? All of the following histologic features can be seen on his biopsy. Which of the following histologic features can be seen on his biopsy? Okay. A. Tubules show absent Sertoli cell. B. Thickening of basement membrane. C. Decrease in interstitial cells of Leydig. D. Normal spermiogenesis. So what do you think is the answer? Anyone? Right. So the answer over here is B. Okay, the right answer over here is B. So this question, students, what did it ask you? So let's go back to the question. Why is the answer B? So this is a child, okay, this is a small child who is detected to have an empty scrotal sac. What does that say? Which means the testis is undistended, right? And then following histological features are seen. So that was the question. Okay, so what do you see here? Before we see the abnormality over here, so the correct answer is B. Why? Because this is a cryptorchid testis. Okay, the tubules show absent Sertoli cell. So this is the tubule. So before I explain this, let's move to the next picture where I have put the normal testis, how histology, how it looks. Okay, so what you're seeing here is the normal histology of the testis. Okay, so what you're seeing, these tubules are your seminiferous tubules. Do you see these? So these are your seminiferous. Okay, so these have a basement membrane, and what do you see here are these tiny structures over here. They are your Sertoli cells, and the normal spermatogenesis occurs over here. And between these two, you see some empty space here and some cells, okay? Very few cells here. So this is your interstitial cells of Leydig, right? So these are the interstitial cells of Leydig. And this is the connective tissue which is present. So this is the normal histology of testis, okay? So the normal histology of testis, now you all are aware of the normal histology of testis. So let's move back to the question now. So what was happening here? So this was your microphotograph where you're seeing a tubule, right? But what has happened to the basement membrane? it is thickened. Okay, it is thickened. And are you seeing all those blue dots over here? No, they are reduced, right? So all you're seeing is few cells which all look alike. So these cells are the Sertoli cells. So these cells are Sertoli cells. So this is almost like a Sertoli only cell, right? So this particular biopsy, so let's look at the options again. Tubules show absent Sertoli cell. This is a false statement because you're seeing a lot of Sertoli cells here, right? Next, thickening of basement membrane. Yes, the basement membrane over here in this biopsy is thickened. So thickened basement membrane is the right answer. Apparent decrease in interstitial cells of Leydig. Compared to the previous photographs, can you see these interstitial cells? They have increased in number, right? They're compensating, they're increasing in number. So apparent decrease is a wrong statement. Normal spermiogenesis. Do you see normal spermiogenesis here? No, you don't see normal spermiogenesis. Normal spermiogenesis looks like this. It's filled up, right? But here you are seeing only Sertoli cells. So again, this is a wrong answer. Okay. So the right answer here was thickened basement membrane. So what were we discussing? So this was a child and with cryptorchidism. So what is cryptorchidism? All of you are aware. It is absence of one or both testes in the scrotum. Okay. So before you remember this, please, you should know what testicular descent is, embryogenesis of testicular, what week of life development does it occur. Okay. What is the transabdominal route and what is the inguinoscrotal descent route. So these two things that you should know in your embryogenesis. Okay. And then so this occurs, so undistended testis is seen in cryptorchidism and also in few conditions or few syndromes wherein you see testicular dysgenesis, like your Klinefelter syndrome or your Prader-Willi syndrome, right? So all these syndromes we'll talk in detail when we do the particular subject, but remember that these syndromes which are associated with testicular dysgenesis, even here, if the biopsy is done, you see this, okay? All these chromosomal anomaly syndromes are also, some of them are associated with testicular dysgenesis and you have a similar picture, okay? And one more important thing that you need to know in these cryptorchid testes is they are more prone for something called as germ cell neoplasia in situ. Okay, this is the standard used, okay, GCNIS. It stands for germ cell neoplasia in situ. So yes, these testes, undistended testes, are more prone to this, and this can further lead to seminoma or other germ cell tumors. Okay, so that is something you need to know. So last NEET you had a question wherein they had, so let's move on to the next thing. So this, so what can you see here? This is again a testicular biopsy. Okay, this is a testicular biopsy again. And so the last time the question was, it was a male in his say 30s or 40s and he presented with a unilateral scrotal mass. So, and the histology was given here. So you had to diagnose what it is. Okay, so this was, so this is the histology of seminoma. Okay, so seminoma is another important question which had occurred just last year, but still you need to know. So what is the histological picture? So this is the most common germ cell tumor of the testis. Okay, most common germ cell tumor of the testis is seminoma. It is, your dysgerminoma is a counterpart of seminoma. Okay, they are germ cell tumors. So you need to be thorough with germ cell tumors of the testis, germ cell tumor of ovary, what hormones are secreted. Okay, so all these things you need to know. So let's concentrate on what is seen in the microscopy or the biopsy, right? So here you're seeing some cells. So basically, if you remember your histology drawings in your second year, okay, so you see some big cell with a prominent nucleus and a nucleoli, and you're seeing vascular channels. Okay, so these, all these prominent cells again are thrown into lobules. Okay, so if you're seeing tumors in lobules, like this is a lobule, so this is the intrinsic blood vessels here, these red things, you know, which I'm again highlighting in red. These are the intrinsic blood vessels, and you have these cells with prominent nucleoli and they have abundant cytoplasm. Okay, again a very important feature is abundant cytoplasm with prominent nucleus and nucleoli. So this, along with, are you seeing here there are some dark dots? Okay, they are nothing but your lymphocytes. Okay, so these dark dots are your lymphocytes. So if you are seeing sprinkling of lymphocytes with lobules of tumor cells with prominent nucleoli, then they are hinting you towards seminoma. And the history will usually say he has raised LDH, he has a well circumscribed lesion. Okay, when they do a testicular imaging, there is a well circumscribed lesion in the testis. Okay, so they are talking about seminoma, right? Okay, so I think you're clear with the question. So this particular question, I showed you the biopsy features, the microscopic features of a cryptorchid testis. Okay, again testicular atrophy is also different. Okay, so what you find in testicular atrophy, what you find in a cryptorchid testis, and what you find in a seminoma, all these microscopic findings you should be thorough with. So we'll move on to the next question now. So this is question number 14. Let's look into the question now. This is a 60-year-old male. Okay, he's a non-smoker, presenting with cough and breathlessness, and gives an occupational history of sandblasting and stone cutting. Now the chest X-ray was done. He goes to a physician and a chest X-ray was ordered, and the chest X-ray is showing you eggshell calcification. So what is the diagnosis? Is it A, silicosis, berylliosis, C, asbestosis, or is it a simple bronchial asthma? What do you think the answer is? Anyone? So the answer over here for this question is A, silicosis. Okay, let's go back to the question. I'll help you understand. So this is a old person. Okay, it's a 60-year-old male. He's a non-smoker. So there is something which is leading you to the answer. Again, he is a non-smoker. Okay, he's presenting with cough and breathlessness here, and they're giving you a occupational history. So this is a occupational hazard that we are dealing with. Okay, and what does he do? He used to work in a sand blasting and stone cutting factory. So he is getting exposed to the silica dust, right? And his chest X-ray is again showing eggshell calcification of the lung. So they are asking you to mark silicosis. Okay, so this is a pneumoconiosis. Remember? Okay, this is a type of pneumoconiosis. And the pathological features here, what you see, this is your silicotic nodule. Silicotic nodule. Okay. So there are two stages. There is an early stage and there is late stage. So there's something you need to remember about the silicosis is silica inhalation causes this. Okay. And just because once you visit a sandblasting factory or a sandblasting mine doesn't mean that you'll land up with silicosis. There should be decades of exposure. So this person was around 60 years of age. Okay. And throughout his life, when he was working, he has been exposed to this. And what is the pathology which occurs? There is progressive nodular fibrosing pneumoconiosis which is occurring in the lung. And usually it occurs and it takes the upper zones of the lungs are the ones which are involved. It settles there. Okay. So initially it presents like this. It is a organizing granuloma here with lot of pale black. So if you can see, there are some brown dust like particles over here. So this usually starts in the upper zones of the lung. So on constant exposure, it leads to a fibrosed stage which is called as your silicotic nodule. Okay, and this particular nodule is because of deposition of silica along with long-standing calcification. So fibrosis and calcification occur in late stages. So this is a organized fibrosis and calcification, and when this occurs on your chest X-ray, the finding is a eggshell calcification. Okay, eggshell calcification. So this is seen in silicosis, remember students. And then when we do a biopsy, okay, say the person has undergone a autopsy and the biopsy has come, we usually see these kind of silica nodules along with needle-like spicules, and when we see under the polarizer, these are birefringent. Okay, and these are 5 micron or less because they have to enter the alveolar, right? So this is the microscopy in silicosis, and your radiological finding is eggshell calcification. Again, all pneumoconiosis, berylliosis, silicosis, asbestosis, all of this are a question in itself, very important question, and you need to know these topics. Let's move on to the next question. So next question is question 15. Let's see if anybody can answer this. Sorry. So following is the gross appearance of kidney. So they've given you a gross kidney specimen. Which statement is false with respect to this disease? So A, patients present with polyuria. B, tubular acidosis is noted. C, arises from the convoluted tubules. And D, there is a familial juvenile nephronophthisis which is autosomal recessive. So what do you think the answer is? First of all, any answers? Okay, so this particular question, here we are talking about medullary sponge kidney. Okay, so you see the kidneys here, the gross picture, it's become like a sponge, right? Remember SpongeBob? So how is he with all these kind of holes? So this is like a sponge. So these kidneys, but what has happened? Have these kidneys shrunken? Have these kidneys become small in size? No. So that is also one of the feature here. The kidneys do not shrink and they do not become small in size. They are not contracted kidneys. You need to know the conditions where you have contracted kidneys on gross also. Okay, we'll discuss all these things in great detail when we are doing renal. But now we are just doing the important questions, and let's stick to the main important points. Remember, this is medullary sponge kidney. It's a cystic kidney disease, and here you don't have shrinkage of the kidney, and it looks like a sponge kidney. Okay, so these patients, yes, they present with polyuria. So option A is correct. They present with a lot of urine. Okay, but the urine fails to concentrate. Okay, and then these people can also present with hematuria. Usually medullary sponge kidney is a asymptomatic condition. Okay, sometimes it is asymptomatic, most of the times it's asymptomatic, but it is incidentally discovered when the patient is coming with unexplained polyuria and tubular acidosis. Okay, so tubular acidosis is also right. So they are asking you to mark the false question, the false option. So next, let's see. This arises from the convoluted tubules of the kidney. So this particular thing is a false statement. So remember, students, that medullary sponge kidney occurs from the medullary collecting ducts. Okay, so it occurs in the medullary connecting ducts and not in the convoluted tubules. Okay, so this option is wrong. The next option was familial juvenile nephronophthisis is autosomal recessive. So this particular sponge kidney can be sporadic or can be familial. When it is familial, it presents as familial juvenile nephronophthisis, which is autosomal recessive. Even if you don't know this, it's okay. But please remember that The origin is from collecting ducts. Now this is the catch there. Okay, so this is a simple question, and it was an easy gross also. Okay, so now a lot of image-based questions are asked. So you need to prepare yourself to see these images and to have a photographic memory. Okay, let's move on to this. So I already told you, so they're usually asymptomatic throughout their childhood and their adulthood also, but even if they present, it's only in the adulthood. Okay, and they have normal renal function. Again, this is an important thing. It can come as an MCQ. So what do you see? You see calcifications, you can see renal stones, there will be hematuria, and sometimes they can also go on to have infections. Again, does not progress to end-stage renal disease. So medullary sponge kidney is not a cause of end-stage renal disease. Okay, end-stage renal disease is not C. Next one, it is diagnosed with IVP. Yes, it is diagnosed by an IVP. Okay, so I hope you got this question. Let's move on to the next question. Okay, so this is a very giveaway question that I've put. So this was a last year question. So let's see. I think this most of you can answer. So this is NHCOV cells, and these cells are pathognomic for. So that was the question. So acute rheumatic fever, Liebman-Sachs endocarditis, syphilitic aneurysm, and D is Marfan syndrome. So what do you think the answer is? So the answer over here is A, acute rheumatic fever. Okay, so NHCOV cells are seen in acute rheumatic fever. So let's see what acute rheumatic fever is all about. So you know it occurs after a bout of, okay, so you have to be pakka with acute rheumatic fever, Jones criteria, okay, all these things, which group of streptococci causes it, okay, hemolytic or non-hemolytic, so all these things you have to know. So I cannot discuss all this in this class because of the shortage of time. Just giving you points, because if you don't know, you have to go back, look before your exam. And so where was I? Okay, so I was talking about this pathological feature, and this is seen in acute rheumatic fever. So then it goes and affects the heart. Okay, so they have a prior history of pharyngitis, and now they come with rheumatic fever and rheumatic heart disease. Can be acute, can be chronic. We are talking about this acute disease here, and then it is a pancarditis. Remember, rheumatic heart disease is a pancarditis. What do you mean by pancarditis? Which means it's affecting all the layers. Okay, it's affecting all the layers. So what are the layers you have? You have your endocardium, you have your myocardium, which is the muscle, and you have your pericardium, right? So it is affecting all the three areas. Okay, so what is the endocardial lesion called, students? Very important, your endocardial lesion, I'll put it here. Your endocardial lesion is your McCallum's patch. Okay. Okay, so which is the most common valve which is involved? Mitral, right? And what happens here? You have vegetations which goes and sits on the valves. Again a question, so you need to also know the vegetations in pathology, vegetations of the heart, where all they sit. And remember, here we are discussing only about rheumatic heart disease, and in rheumatic heart disease the vegetations are along the line of closure. Okay, along the line of closure. This is a question again. So your vegetations are along the line of closure, and your endocarditis it causes, and there you have something called as the McCallum's patch, which is nothing but calcifications, and most commonly seen in the left atrium. Okay, So it's seen in left atrium, understood? So endocarditis, McCallum's patch, left atrium. That is about endocardium. Now myocardium you have, we'll discuss what is seen in myocardium. In pericardium, what you see is adhesive or fibrosis. So this is adhesive pericarditis. So it causes inflammation in all the three layers. So it causes a pancarditis picture. And in the endocardium, you see McCallum's patch. In the pericardium, you see adhesive pericarditis. What do you see in the myocardium? In the myocardium, you see something called as Ashkoff bodies, right? So what is Ashkoff bodies? So now this Ashkoff bodies was first discovered by Ludwig, okay? And Ludwig Ashkoff. Okay, so this was the person who discovered this bodies and it's named after him. And it's seen in acute rheumatic heart disease. And it occurs with 3 stages. Okay, there are usually 3 stages which occurs. Stage 1 is called as the early exudative stage. And this occurs usually around 4 weeks. So these stages are what you see in the myocardium, okay? What are the changes you see in the myocardium in rheumatic heart disease, acute rheumatic heart disease is what what I am showing you over here. Don't know if you could see that. It was Ludwig Ashkoff who discovered this. The body is named after him, Ashkoff body. It is seen in the myocardium and there are 3 phases which occurs. One is the early exudative phase. Okay. So in the early exudative phase, what happens? This occurs around 4th week after the infection and you have recruitment of macrophages and fibroblasts to the area of injury. Okay. The next phase is called as a granulomatous phase. Granulomatous phase, and in this particular phase you have this Ashkoff body which is seen where you have all these fibroblasts and macrophages sitting here forming a granuloma in the myocardium. This is Ashkoff body. You see the striated fiber over here. This is the skeletal muscle of the heart and this is the Ashkoff body. Now, in this, okay, in the late stages, you can see something called as Ashkoff cells. Okay, so these cells are your modified macrophages, which is the Ashkoff cells. And something very typical about these cells is they are also called as the caterpillar cells. Okay, why are they called as caterpillar cells? Because you see the cell here. This is the condensed chromatin which is occurring like a caterpillar. That is why it is called as a caterpillar cell or the Ashkoff cell. Okay, so this is the cell. So this is the thing you have to remember. And then there is a late stage. Okay, so this was the first stage, early exudative stage, granulomatous stage and a late fibrosis stage. So these are the stages you see in, just like in pneumonia you have your red, grey, hepatization, so all those things. So these are the stages which is seen in the light microscopic biopsy of a rheumatic heart. You need to know, and it is the granulomatous stage that you see your Ashkoff bodies and these cells are seen and these cells are pathognomic for rheumatic, acute rheumatic fever. Okay, so that was the question here. Let's move back to the question. So they are pathognomic for acute rheumatic fever. So I hope I have made myself clear. Let's move on to the next question. This is question number 17. Okay. So let's read this question here now. So question number 17 is, a 3-year-old boy presented with orbital and jaw swelling. So this is a 3-year-old boy with a orbital and a jaw swelling. Biopsy was done. Okay. And histopathology microphotograph is given below. What is your diagnosis? So, any answers? So the answer over here is A, Burkitt lymphoma. So let's read the question again. So first of all, this is a child. It's a 3-year-old child. Okay. And he's presenting with orbital and jaw swelling. So this is a head and neck swelling. Okay. And biopsy was done and the biopsy is showing this. So what are you seeing here? Okay, of course this is lymphoma because you see most of these cells here, blue dots. So first of all, remember lymphoma is a small blue round cell tumor. Okay, lymphoma is a small blue round cell tumor, and these cells over here are giving you a starry sky appearance. So this is a Burkitt's lymphoma which is giving you a starry sky appearance. So let's see this biopsy over here. So this is just to show you how a starry sky looks. And something more about Burkitt's lymphoma. Burkitt's lymphoma, you all know it's a non-Hodgkin's. It's a non-Hodgkin's lymphoma. And this non-Hodgkin's lymphoma is a B-cell lymphoma, right? It's a B-cell lymphoma. It occurs in 3 forms. It can either be endemic, it can be sporadic, or it can be immunodeficient. Immunodeficiency associated. Okay, like it can be associated with HIV. Okay, and then you have EBV infection, which also triggers Burkitt's lymphoma. What is the genetic translocation which is occurring? It is the c-Myc translocation to the IgG heavy chain loci. Okay, so this particular proto-oncogene is located on chromosomal 8 and that translocates. So I hope all of you have gone through neoplasia and you know what is c-Myc. So Myc is a class of proto-oncogenes. Okay, so they are proto-oncogenes, and these proto-oncogenes, when they get regulated, it causes translocations, or when it's upregulated, then it causes malignancy. Okay, so when it is overexpressed, it causes malignancy like CA prostate, etc. When it undergoes translocation, that too translocation 814 specifically causes a lymphoma, which is a B-cell lymphoma, non-Hodgkin's lymphoma, called as Burkitt's lymphoma. So obviously this expresses all the B-cell markers. Then you have CD 19, 20, 22, 79A. All these are specific for your B-cell. PAX5. So all these things are questioned. That's why I'm taking my time and reading it slow. Okay, CD markers, your cluster differentiation markers in each lymphoma is important. We'll have a separate session for this where I'll help you, give you mnemonics and help you learn all the CD markers. Okay, so for now let's stick to Burkitt's lymphoma. And then these are your germinal center marker 10 and BCL6. These are also expressed. Most importantly, your c-Myc is positive. Again, this is a highly aggressive lymphoma. Right? So what do you mean? Whenever it is highly aggressive indolent B-cell lymphoma, which means they are proliferating a lot. So proliferating a lot means their Ki67. Ki67 is a proliferative marker. Okay, it's a proliferative index. So when we get a biopsy like this, what they do something called as immunohistochemistry for prognostication and to confirm the diagnosis, because all the lymphomas will look similar. Of course, this is a beautiful picture where you're seeing very nice starry sky appearance. Why do you have this starry sky appearance? Because these are your tingible body macrophages. You know what are these empty spaces with dots? They are your tingible body macrophages, which is giving the starry sky appearance. Okay, because they are proliferating and they are dying, apoptoting in such a progressive form that they form these. There are macrophages which eats away these cells. Okay, so these proliferating cells which are taken up by the macrophages result in something called as tingible body macrophages, which gives this appearance of starry sky. Made myself clear? So it is an aggressive form of lymphoma. It's a B-cell lymphoma. It occurs in an endemic, sporadic and immunodeficiency associated. So if the history is telling you it is an African child, so it's more common in this geographic location and there it is endemic, okay, especially with the malaria. So they are seen, and then sporadic forms have no such predilection. They can occur anywhere and in any age. These are usually in children and in immunodeficiency associated individuals with HIV or EBV infections also you can see this, okay. And another marker is membranous positivity for IgM with light chain restriction. So this is also seen. So this is about Burkitt's lymphoma. Let's move on to the next question. So this is question number 18, a very simple question. Okay. So this is a 49-year-old male and he is presenting with massive splenomegaly. Okay, it's a adult male with a massive splenomegaly. His differentials include all except. So you have to mark the false answer. So A is CML, B polycythemia vera, D C hairy cell leukemia, and D aplastic anemia. What do you think the answer is here? So they are simply asking you that massive splenomegaly is seen in all of these conditions except. So the answer over here is aplastic anemia. Okay, so this is the answer. You do not see splenomegaly in aplastic anemia. What is CML? What is polycythemia vera? All these are myeloproliferative syndromes, right? So there, of course, you see splenomegaly. What happens in hairy cell leukemia? Hairy cell leukemia is the differential for massive splenomegaly. Remember? Massive splenomegaly. So hairy cell leukemia usually doesn't involve the lymph nodes. It involves the bone marrow. It involves the spleen. Okay. So you see massive splenomegaly. Okay. So again, you need to know the translocation apart from your Philadelphia. What are the translocations are there? You need to know. Then polycythemia vera. All the myeloproliferative, you have JAK2 STAT mutations, and especially here in polycythemia vera, you have one mutation called as JAK2 V617F, very specific to polycythemia vera, and this has been a frequent favorite question. Okay, polycythemia vera. It's a myeloproliferative syndrome associated with this mutation. Hairy cell leukemia, any guesses? Anyone? What is the mutation here? So here, of course, it's a B-cell lymphoma. So you'll have all your B-cell markers. Apart from it, you have, okay, you have, when you go to the mutation, cytogenetics here, you have BRAF, BRAF mutation. Where? At this V600. So this is the location of your mutation. Okay, so this is very specific for hairy cell leukemia. So CML mutation, polycythemia mutation, your hairy cell leukemia mutations, all this is important. Moving on to the 19th question now. So here he is a 45-year-old patient coming with fatigue and knuckle pigmentation. Easy question, okay? So he's coming with fatigue and knuckle pigmentation and a swollen beefy red tongue. So the complete hemogram is ordered by his physician and this reveals anemia. following is seen in this condition except. So what do you think is not seen? First of all, let's see the options, wait for your answers, and then I'll tell you what condition this is. Okay. A. Pancytopenia. B. Triad of oval macrocytes, Howell-Jolly bodies and hypersegmented neutrophils. C. Reduced MCV. D. Hypercellular marrow with megaloblasts and megakaryocytes. So what do you think the answer is? So the answer over here is, so this is a megaloblastic anemia. Okay. He's a old patient and it's a male patient, let's say. He's coming with fatigue and knuckle pigmentation. Fatigue is because of your anemia and knuckle pigmentation is seen here and a swollen red tongue. All these are clinical signs of megaloblastic anemia. So the physician has ordered complete hemogram and diagnosed him as a megaloblastic anemia picture with the peripheral blood smear. So they are asking what all is seen in this condition except. So pancytopenia, yes. So in megaloblastic anemia, remember students, there is a pancytopenia picture, which means, what is pancytopenia? Pan means everything, like we just read about pancreatitis, right? So similarly, pancytopenia is all the cell lineage. You have your erythroid, you have your myeloid, and you have your RBCs, you have your WBCs, and your platelet in the peripheral smear. So all these three are reduced. So that is cytopenia, pancytopenia. And what do you see on the blood smear? You see macrocytes obviously, and these macrocytes are oval macrocytes. There is Howell-Jolly bodies and there are hypersegmented neutrophils. So all these are a triad which is usually seen in the peripheral smear. Reduced MCV. Do you see reduced MCV? No, this is your second year knowledge, right? You see increased MCV, usually more than 100 femtoliters, right? So whenever the MCV is so raised, you think of megaloblastic anemia. Then hypercellular bone marrow with, so this statement is true, this statement is true, reduced MCV is a false statement, and hypercellular bone marrow with megaloblasts and megakaryocytes is also a true statement. So when they do bone marrow aspiration, they see a hypercellular marrow. The bone marrow is hypercellular. Okay. Surprisingly, in the peripheral smear, everything is less. But when it is aspirated from here, you see that it is hypercellular. Okay. And it is filled with megaloblasts and megakaryocytes. Okay. So let me also show you this picture because they can give you this as an image also. So this image over here is a peripheral blood smear. Okay, peripheral blood smear. What do you mean by peripheral blood? When they draw blood from the periphery, from the vein, and then they check. So this is the peripheral blood smear where you're seeing this is a hypersegmented neutrophil. So neutrophil usually won't have around 6 lobes. So here if you can count the lobes, it is multilobated, right? So this is a neutrophil 1, 2, 3, 4, 5, 6, 7, 8. You are seeing 8 segments. So this is called as a hypersegmented neutrophil, very classically seen in megaloblastic anemia. So these are the findings in megaloblastic anemia. Okay, so you also see decreased RBCs, yes. You see increased MCV, I already told you. You see hypersegmented neutrophils, yes. And you know where B12 is involved in which pathway. So you also see increased homocysteine levels, yes. So megaloblastic anemia, B12, folate, the pathways, all these things are a question in itself. You should know these things, okay. And this is a bone marrow picture. Normally the erythroid cells are more, but here the myeloid cells are more, and these are your megaloblasts. Okay, megaloblasts. And also you have megakaryocytes, that is, so the big platelets. That's not shown in this picture. Okay, what are these? These are nucleated RBCs, erythroblasts. Okay. So let's move on. I hope you got this question. If you want to see it again, the reduced MCV was wrong. This was megaloblastic anemia where you see increased MCV. Iron deficiency anemia, B12 deficiency, folate, pernicious, pathway of iron absorption, all these things are very important and you need to know them in and out. Okay, when we do anemias, we'll discuss nutritional anemias in detail and we'll discuss all these things. Okay. Moving on to the next question, question number 20. So this is a 57-year-old male who has, 57-year-old female, it's a woman who has felt a lump in her left breast for 4 months. Okay. A lumpectomy was done with axillary node sampling and the IHC has been performed, which was E-cadherin and HER2 negative. Okay. Which shows IHC staining shows E-cadherin positivity and HER2 negativity. No, here the question is saying both are negative. Sorry, I mistook the question. So both are negative, but there is presence of ER and PR as positive. And the biopsy is showing cells like this. Which of the following is the most likely diagnosis? So the history itself is telling that this is an old woman with a lump in her breast and axillary lymph node sampling was also done, which means they've done a radical surgery. Okay, so they're talking about CA breast here. And IHC staining was done, which is shown E-cadherin negativity. So remember students, E-cadherin is a marker for ductal breast carcinoma. And they are saying that this is negative, which means they are telling you it is a lobular carcinoma of the breast. And what do you see over here? You are seeing these malignant cells in a line. Okay, so second year, so what is this? This is Indian file pattern. Okay, so this is the Indian file pattern of arrangement of, these are the red Indians who used to go in line like this, one behind the other. So that is how the malignant cells also appear in the biopsy. And these cells have a signet ring shape or a plasmacytoid appearance. That is, they have a pinched out nucleus. And so I can see Suraj replying and saying option A. Hi Suraj, sorry I missed that option of yours. So let's see you answer the next question. Okay, we'll discuss. Sorry, I'm reading the chat a little late. So here you're seeing signet ring cell. So this is Indian file pattern, signet ring cells. All these things are seen in lobular carcinoma breast. Let's move on to the next question. So again, there is something called as Verrucay bodies. Okay, so Verrucay bodies are seen in meningioma. Option A is meningioma. Option B is astrocytoma. C schwannoma. D dermatofibroma. So what do you think the answer is here? So the answer over here is schwannoma. Okay, Verrucay bodies are classically seen in schwannoma. So this is how the appearance looks like. So Verrucay bodies are seen in schwannoma. Okay, so what is schwannoma? What is schwannoma? So schwannoma is a neural tumor coming from the nerve. It's a peripheral neural tumor and it is a benign tumor. Okay, but again based on the mitosis, based on the atypia, we also categorize, it can go in to become MPNST, that is malignant peripheral nerve tumor, also MPNST. Okay. So this schwannoma is usually well encapsulated, benign in nature, arises from the peripheral nerves, and here you can see these spindle cells. Spindle cells are seen, and these spindle cells give, so this area does not have blue appearance, so suddenly this area has, right? So this palisading of the nucleus of these fibers are called as Verrucay bodies. So this tumor has a hypo and a hypo means nothing, and hypercellular areas. So whenever you see a tumor with hypo and hypercellular area, please remember they are asking you to mark schwannoma, and Verrucay bodies are seen in schwannoma. Okay, this is the palisading bodies here. Verrucay bodies. Next, I hope you got this clearly. Now, all these are one-liners. I'm just putting this because to just revise for your exam. So Kaposi sarcoma is associated with HPV 8, 16, HHV 8, HPV 16, EBV, HSV 2. What do you think is the answer? The answer over here is HHV 8. So what is Kaposi sarcoma? It is a highly aggressive vascular tumor. Okay. Usually seen in immunodeficient individuals, and it's associated with HHV 8. You see a lot of proliferating vessels, extravasated RBCs with significant atypical cells. Okay, so this is associated with HHV 8, Kaposi sarcoma. Moving on to the next question. For performing a retic count in hematology laboratory, which stain is used? So you also need to know. So this question I've just put up because they are also asking you a lot about stains in your NEET exam. Okay, or if you go for your subject specific exam, INI-CT, they are asking you stains. Okay, so for performing a retic count in hematology laboratory, which stain is used? Is the answer brilliant cresol blue A, B H&D stain, C pass stain, D Pearl's Persian blue stain? What do you think the answer is? So the answer over here is A, brilliant cresol blue. Okay, so you need to know about the stains first of all. What stains are used in hematology laboratory? Hematology means so pathology has hematology, pathology has clinical pathology, pathology also has a section called as histopathology, molecular pathology. Okay, so hematology is the lab which deals with the blood investigations, the routine blood smear making. They do all the blood tests, your coagulation profiles. So all these things are done in hematology laboratory. Sickle cell tests are done, osmotic fragility tests are done. So all these things are done in the hematology laboratory. Okay, blood is drawn and blood is tested. You have clinical pathology laboratory where they do testing like the urine is tested over there. Okay, they do crystals, what is there, Bence-Jones proteins are tested. So all these things are clinical pathology. Then you have surgical pathology or histopathology, wherein the tumor or masses or neoplasms are removed from the body and sent for examination. Okay, so that is surgical pathology or histopathology, where they see the slide under the microscope. So here it's a hematology laboratory. So in a hematology laboratory, what is the routine stain which is used? We use Romanowski's stain. So blood which is collected is made into a tongue-shaped smear. So this is nothing but a peripheral blood smear. Okay, peripheral blood smear. So you remember this blood smear, it was done before, and so you use Romanowski staining. After you make the smear, you use Romanowski staining. So what are the stains which belong to this group? You have your MGG stain, which stands for May Growald Jimsa stain. You have Wright stain, Wright Jimsa modification stain, Leishman stain, and a simple Jimsa stain. Just remember the names and remember that all these things are Romanowski stains. We will discuss each one in detail when we do special stains in hematology and in pathology. We will do special stains in hematology and the special stains which are used in histopathology. So for now, let's stick to the question. The question was, when you do a retic count, what stain do you use? You use a supravital stain, which is brilliant cresal blue. So first of all, what is retic count? Retic count is counting the reticulocytes in the peripheral blood. Okay. So what are reticulocytes? They are immature RBCs. So when the red blood cells are being formed, these are released. These immature precursors are sometimes released and they circulate for a very short time. Okay, so they have to be caught in that short time. They have to be stained when they are live and have to be seen. So that kind of staining is called as supravital staining. Okay, when you're doing it on these live cells. Okay, and what are the two stains commonly used? Methylene blue and brilliant cresal blue. So remember, for a retic count, you use supravital staining, and the stain used, this is the method, supravital staining, and you use new methylene blue or brilliant cresal blue. So these are the names of the stain. Moving on to what is Pearl's Prussian blue. This is also a stain which is used in hematology. Okay, also in histopathology. So this is mainly for iron, not hemoglobin. Okay, for non-heme iron, you use Pearl's Prussian blue. And this is used to indicate non-heme in the tissue. What are the non-hemes? Like ferritin and hemosiderin. Okay, so this is understood. So we will pick these things by doing a Pearl's Prussian blue. We will discuss all this in detail, as I said, in the special stains class. So this is how it looks. So bone marrow with Prussian blue staining for iron, non-heme iron. Okay, what is the principle of this test? Okay, all these things we will read. Next, so this is the last but one question for the day. So this is a sample and they're collecting it for direct antiglobulin test, also called as the direct Coombs test. Okay, and it is collected in which color vacutainer? Is it collected in A, lavender, B, red, C, grey, or D, blue? What do you think is the answer? So a direct antiglobulin test, you collect it, the correct answer over here is D, blue. Okay, so what is a direct Coombs test? Now in a direct Coombs test, what you're doing is you're collecting the RBC of the patient which already has antibodies and you're exposing it to Coombs reagent, okay, which is an anti-human immunoglobulin antibody. Okay, so then this reaction is formed and appears as a agglutinate, and this is picked up and your direct Coombs test is interpreted. And for example, okay, when the baby's blood is positive for presence of mother's antibody on the surface of the RBCs in case of erythroblastosis fetalis, you will do a direct Coombs test. When the baby has hemolytic anemia, when the baby has jaundice, you do this direct Coombs test. So the question here was, how do you collect a sample? So what do you need to collect? You need to collect the patient's RBCs, because these patients' RBCs will have antibodies attached to them. There will be a complex. So that is what you need to test. So can you see that in the serum? No. So you need some blood vacutainer which does not separate the serum and the blood components. So you need a good anticoagulant to be present. So in your red vacutainer, do you have any anticoagulant? Do you know the colors of the vacutainer first? We will see that picture. Then we'll come back to the question. Okay. So very important, this is your routine day in and day out vacutainer, EDTA vacutainer. Now EDTA vacutainer, again the ratio of what kind of EDTA is used, whether it's sodium or potassium EDTA, what is the difference, what is the ratio of anticoagulant to blood ratio, all these things we will do in detail. But now remember, EDTA is usually used for your CBCs, blood counts, sometimes for all the time for ESR, unless they prefer a black vacutainer. For HbA1c, because you're seeing glycosylated hemoglobin on the RBCs, right? So you need the RBCs to be intact. So you want a good anticoagulant vacutainer. So that is your EDTA vacutainer. Now this particular thing was your DCT. So then you have this sodium citrate vacutainer, where you do coagulation testing, also for PTINR, for APTT, D-dimer, etc. So this also is important. Another vacutainer routinely used is your plain vacutainer, which means there is no anticoagulant here. There is no anticoagulant in this particular vacutainer. It is empty. Okay, and this is usually it is used in the biochemistry laboratories. Okay, and for your hormone testing. So all of it, and also for the indirect Coombs test, because you need to use the patient serum. So in indirect Coombs test, red vacutainer, colored vacutainer is used, and in direct Coombs test, preferably sodium citrate vacutainer is used. If this is not there, still some labs prefer EDTA, but the first choice is sodium citrate vacutainer. So the black vacutainer is for ESR, green vacutainer is heparin, and the best vacutainer to estimate glucose level is your fluoride or oxalate vacutainer. Okay, it's a little grayish. It's gray in color. So I think this is another very important question. So if you go back to the question, so sample for direct Coombs test is collected in which color vacutainer? Not the EDTA vacutainer, not the serum vacutainer. So this gray I told you was for glucose, right? So not in that, but yes, in the sodium citrate vacutainer, in your sodium citrate vacutainer, which is a blue cap vacutainer. Okay, moving on to the last question of the day. So all are true about apheresis except. So all are true except. So identify the false statement. A, it is a blood bank procedure. B, it can be therapeutic. C, whole blood is withdrawn and separated into components. And D, platelets cannot be separated. So what do you think is the answer? So it is a blood bank. First of all, you need to know what is plasmapheresis, what is apheresis. This is a blood bank procedure, yes. It can be therapeutic. True, it can be therapeutic in conditions like Waldenstrom's macroglobulinemia, Guillain-Barré syndrome. They take out the plasma so that they are freed of the autoantibodies, right? So that is, it is therapeutic. And whole blood is withdrawn and separated into components. So this is a kind of transfusion wherein the patient before elective surgery can himself, if the HB is good, can himself give his own blood with the apheresis procedure, and the blood can be separated into components and can be stored. Okay. So this is correct, this is correct, this is correct. It is withdrawn and separated into components, just like other blood donation procedure. Platelets cannot be separated. So this particular statement is not true. So all the components can be separated in apheresis. Okay, apheresis is a blood bank question, so that's why I've put it here. We'll discuss in detail when we do our session on blood banking. Okay, so it is a apheresis is a blood bank procedure. It can be therapeutic, yes. And whole blood is withdrawn and separated into its components. Yes, this is also correct. And option number D, where they say that platelets cannot be separated, is false. All the components can be separated. So when you look at the question only, you know that these two are the options which has the right answer, right? So it is platelet cannot be separated is the false statement. Right, students? So I think this was the last question. I hope you enjoyed the class. So we are just covering main important points, and we're not doing this in detail, but yes, keep following our YouTube channel. So we'll put up topics, and now we are doing only important questions, so we just stick to the important points, but when we do individual topics, we'll be going in great detail. Okay, hope you had a good session, and today we have another session, so please also log in and check our schedule time and again, and hope this was informative. Thank you.